My name is Sarah Muller-Robbins, and I am the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled Neonatal Hyperbilirubinemia, an update and review of clinical practice guidelines. I would like to review some information before we get started. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the Partnership's website and YouTube channel. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box, and the speaker will respond to as many as possible at the conclusion of the presentation. Now I would like to introduce today's speaker. Dr. Purificacion F. Tumbaga is a neonatologist with 21 years experience. Her special interests are in the area of bedside critical teaching, neonatal sepsis, particularly perinatal GBS infections, hyperbilirubinemia, PPHN, HIE, BPD, and neonatal nutrition. She has completed her pediatric residency at Monmouth Medical Center in Long Branch, New Jersey, and Neonatal-Perinatal Medicine Fellowship at UC Irvine Medical Center in California. Dr. Tumbaga's journey has been diverse and challenging in academia and private practice, but also extremely rewarding. She has traveled around the country and worked at children's hospitals on the West and East Coasts, including Hawaii. She enjoys teaching and has given lectures throughout New Jersey and California. She has retained a positive spirit and unquestioned commitment to the care and healing of newborns. She recently moved back to New Jersey and is currently affiliated with Hackensack Meridian Health at Mountainside Medical Center and JFK University Medical Center. Welcome, Dr. Tumbaga, and thank you so much for joining us today.
Good afternoon, everyone, and welcome. Thank you, Sarah, for the kind introduction. I am delighted to be here and talk to you about neonatal hyperbilirubinemia, focusing mainly on indirect or unconjugated hyperbilirubinemia in newborn infants 35 weeks or more gestation. I have nothing to disclose. At the end of the talk, you will be able to recognize jaundice as a sign of hyperbilirubinemia, define neonatal hyperbilirubinemia, and identify risk factors, explain bilirubin metabolism, and list causes of indirect hyperbilirubinemia, describe the clinical practice guidelines, how it evolved to decrease the incidence of hyperbili and bilirubin encephalopathy, compare and contrast breastfeeding and breast milk jaundice, recognize the importance of screening and post-discharge follow-up, and understand the management and treatment of unconjugated hyperbilirubinemia. Next slide, please. We begin with some abbreviations and definitions. American Academy of Pediatrics, AAP, Tsb, total serum bilirubin, TB, total bilirubin, TCB, transcutaneous bilirubin, bind, bilirubin-induced neurologic dysfunction, ABE, acute bilirubin encephalopathy, CBE, chronic bilirubin encephalopathy, also known as kernicterus. Next slide. Benign or physiologic hyperbilirubinemia is a transient and normal increase in serum bilirubin levels occurring in almost all newborns. Significant Neonatal hyperbilirubinemia is defined as total bili greater than 95th percentile on the R-specific nomogram in newborn infants 35 weeks and more gestation. Severe hyperbilirubinemia is defined as total bili greater than 25 mg/cent, and this is associated with increased risk for developing BINE. Extreme hyperbilirubinemia is defined as total bili greater than 30. This is associated with significant increased risk for bilirubin encephalopathy and likelihood of kernicterus. Next slide, please. When the prebilirubin crosses the blood-brain barrier, BINE results, and it can be permanent. BINE occurs on a spectrum, beginning with ABE and progressing into CBE, which is irreversible, also known as kernicterus. Next slide. Neonatal hyperbilirubinemia, it's practically the Achilles heel of pediatrics because it's always going to be there, and we're always going to have that iffy baby who we decide to send home and then worry about. We try to get a feel for the parents and hope that they follow directions and make sure the baby has good intake, voiding, and stooling. We hope that they follow through with a bili check the next day. Or then the onus is on us to check the level the next day, or we pass it on to our colleagues and hope that they remember to check the level. 5% of healthy term infants have a serum bilirubin level exceeding 17 mg/cent. This is a value that the AAP deems significant. However, the vast majority of infants with serum bili levels greater than 20 remain well. Nonetheless, there has been a resurgence of kernicterus since 1990. Next slide, please. Kernicterus is the main reason why we even pay attention to bilirubin. Those few babies that go on to develop acute or chronic kernicterus have fallen through the cracks. This is a preventable disease. If it weren't for kernicterus, we wouldn't even pay attention to jaundice, as in time it goes away. Since 1990, there has been a resurgence in the incidence of kernicterus in term and near-term infants in the US. How did this happen? Next slide, please. Well, back in 1995, Jeff Meisels and others researched the topic and advocated a kinder, gentler approach to treating hyperbilirubinemia. That the number 20 should not be feared as it was in the old days with RH incompatibility, and that healthy infants who did not have signs of active hemolysis should be spared of undergoing such aggressive therapy. Prior to this revelation, babies were exchanged out of fear of the number 20, often unnecessarily creating undue parental stress and untoward risk to the baby. The relaxed approach appeared to be wholeheartedly adopted. Next slide. But it unfortunately led to some babies developing kernicterus, as it came during a time when babies were going home before 24 hours of age. And there was a dramatic, renewed interest in breastfeeding. Mothers left the hospital before adequate lactation counseling, there was little time to teach parents about good voiding and stooling and watch for lethargy and poor feeding. Pediatricians were relaxed about the jaundice. Follow-ups at that time were still 1 to 2 weeks after discharge. I remember in my residency at Monmouth, 1993 to 1996, the clinic was so booked that we made the first follow-up visit at 2 weeks of age, and sometimes even 17 days later. Unlike our protocols today, there was a general lack of systematic assessment prior to discharge. Next slide. There were case reports of term and near-term infants who developed kernicterus at bili levels of 30 to 40. Most had no evidence of hemolytic disease, and the majority were breastfed. These case reports were striking because breastfeeding was previously thought to protect against kernicterus. This is the autopsy finding of a term infant with kernicterus. As you can see, there is prominent yellow staining of select brain regions. For unknown reasons, the bilirubin pigment has predilection for basal ganglia, cerebellum, subthalamus, hippocampus, and brainstem. Neuronal compromise and eventual death ensues. Next slide, please. The pilot kernicterus registry established by Brown and Johnson in the early 90s contains 118 cases of acute and chronic bilirubin encephalopathy occurring in term and near-term infants without hemolytic disease. The peak Tsb range was 20.7 to 59.9. Next slide. 111 of the 118 developed residual neurologic injury or died with kernicterus. The other 7 had ABE, but recovered with normal outcome. It is noteworthy that 9 of the 111 had Tsb less than 25, which is about 8% of all cases. 25 is AAP's cutoff level for healthy term infants. Some would argue that the total serum bili is simply not sensitive enough to determine who is at greatest risk of kernicterus. Wenneberg and others recommend a national campaign to measure the unbound fraction and establish normal values. The mean TSB of these babies on admission was 36.7. It is also interesting that out of the 111 with kernicterus, 30 had greater than 13% drop from birth weight at the time of admission. Comorbid factors were hyperosmolarity, some with sodiums of 149 to 161, and acidosis. Next slide, please. The AAP has reserved the term ABE for the acute changes associated with elevated serum bili levels. Most young people in medicine have never encountered the signs of ABE, as fortunately cases are still relatively few since ROGAM was introduced. Clinically, the baby has changes in consciousness, going from slight stupor or lethargy to deep stupor and coma. There are changes in tone, going from hypotonia to hypertonia, then onto severe hypertonia in the form of retrocollis, extension or arching of the neck, and ophisthotonous, extension or arching of the back. There are also changes in brainstem function. The baby may start out feeding poorly because of poor sucking reflex, then deteriorates to no suck at all. The cry may start out as high pitch and then develop into an ominous shrill cry. These signs are an immediate indication for exchange transfusion. These changes may be reversed by exchange transfusion if performed before deep stupor and coma. Then even an exchange transfusion may not reverse such damage to the brain. Next slide, please. This slide just shows the clinical BIND scoring. A score of 1 to 3 correlates with subtle signs of ABE, 4 to 6 moderate ABE, and a score of 7 to 9 advanced ABE. Next slide, please. The AAP reserves the term kernicterus as opposed to ABE, acute bilirubin encephalopathy, for the chronic sequelae and or death from elevated serum bilirubin level. Next slide, please. The chronic sequelae include a severe form of atyphoid cerebral palsy with uncontrollable extrapyramidal movements, high-frequency hearing loss, paralysis of the upward gaze, so the child will persistently gaze downward, dental enamel dysplasia, and abnormal swallowing and phonation. Intellectual handicaps are less common. Often, a bright person is trapped in a body with uncontrollable movements. Next slide, please. Due to the resurgence of this devastating disease, the AAP subcommittee on hyperbilirubinemia revisited this subject matter and published clinical practice guidelines and a technical report on hyperbilirubinemia. These extensive reports were published in Pediatrics in July 2004. The previous revision took place 10 years earlier in 1994. The 2004 guidelines are based on a careful review of the evidence, balancing benefits and harms. The guidelines underwent extensive peer review and scrutiny by the AAP subcommittee, outside organizations, and experts in the field. Next slide, please. The clinical practice guidelines deal with the management of hyperbilirubinemia in the newborn infant 35 or more weeks gestation, while the technical report is an evidence-based review of important issues concerning neonatal hyperbilirubinemia. Besides the obvious goal to decrease the incidence of severe hyperbilirubinemia and decrease bilirubin encephalopathy, next slide, please. The subcommittee set out to minimize the risk of unintended harm in accomplishing these goals. In other words, they want to make sure we don't escalate parental anxiety or decrease breastfeeding or provide unnecessary treatment or spend excessively on unnecessary tests and procedures. Now, before going further, I think it is important to review the physiology. Next slide, please. Senescent red blood cells get trapped in the reticuloendothelial system of the liver and spleen. They lyse and release hemoglobin. Heme is released from the hemoglobin molecule and is converted to biliverdin, carbon monoxide, and iron in a 1-to-1 ratio by the enzyme heme oxygenase. You can see why the concentration of carbon dioxide in exhaled air can be used as a marker of bilirubin production, particularly in ongoing hemolysis. For every molecule of CO produced, there is one molecule of bilirubin produced by the enzyme biliverdin reductase. It is interesting that humans and other mammals take this further step to produce bilirubin, a potentially toxic product of heme metabolism, instead of simply stopping at biliverdin, which is non-toxic and safe and easily excreted in the urine. Next slide, please. The bilirubin that is produced by the biliverdin reductase is the ZZ isomer, the cis configuration. The ZZ isomer is extremely lipophilic and avidly binds cell membranes, including neurons in the central nervous system. And the vent appearance of the molecule is secondary to the abundance of hydrogen bonding that occurs in this area. The polar portions of the molecule are hidden within and don't come out until the molecule is conjugated with glucuronic acid and made water soluble. Next slide, please. Causes include hemolytic conditions, inherited defects in conjugation, and decreased clearance of bilirubin. Next slide, please. This slide lists the causes of unconjugated hyperbilirubinemia for each category. For instance, increased bilirubin production, such as hemolysis, immune-mediated or heritable conditions. Increased enterohepatic circulation, as in insufficient breast milk or bowel obstruction. Decreased clearance of unconjugated bilirubin as it occurs in prematurity and G6PD deficiency. Metabolic conditions such as hypothyroidism and hypopituitarism. Inborn errors of metabolism such as galactosemia, Crigler-Najjar syndrome, among others. Next slide, please. We all know that neonates are vulnerable. Not only, next slide, please. Not only do they get an extra load of bilirubin by virtue of the shortened lifespan of their red cells, but they have deficient abilities to excrete bilirubin at all points along the pathway. So bilirubin stays around in their plasma longer. The albumin levels are also lower in neonates. Therefore, there is relatively more free bilirubin in the plasma, the bilirubin we worry about entering tissues and brain. Ligandin levels are lower in neonates. Ligandin is the cytosolic transport protein that moves bilirubin into the smooth endoplasmic reticulum for conjugation. The conjugating enzyme uridine diphosphate glucorosyl transferase is also deficient, so less bilirubin undergoes conjugation. And once released into the small intestine, the more alkaline pH of the neonatal proximal intestine promotes hydrolysis of the conjugated bilirubin back to unconjugated bilirubin. Beta-Glucoronidase is another big culprit. This enzyme is very abundant in neonates. This enzyme hydrolyzes bilirubin glucuronides back to bilirubin and glucuronic acid. It is still abundant in newborns because it is an essential enzyme during intrauterine life. The placenta is responsible for clearing bilirubin in the fetus, not the fetal gut. So it must be in the unconjugated form to get it into the maternal circulation. Beta-glucoronidase ensures that this occurs. The intestinal contents of older infants and adults contain bacteria that help convert the conjugated bilirubin into smaller components that gets excreted into stool, giving the stool its orange-brown color. The sterile intestinal contents of newborn makes it less likely for conjugated bilirubin to reach this final pathway out. Also, the slow peristalsis of the newborn gut promotes enhanced enterohepatic circulation of bilirubin, getting it right back into circulation. Next slide, please. So bilirubin stays around in their plasma longer, and with lower albumin levels, there is relatively more free bilirubin in plasma. The bilirubin we worry about entering tissues and brain, causing brain damage. Next slide, please. Now, besides the natural physiologic challenges that most healthy newborns have to face, others have additional challenges that place them at increased risk for hyperbilirubinemia. Hemolysis, polycythemia, bruising, cephalhematoma, all these increase the bilirubin load that is presented to the liver. Glucose 6-phosphate dehydrogenase deficiency, as we know it, leads to hemolysis and increased bilirubin load. However, this is not the predominant mechanism that leads to hyperbilirubinemia in newborns. Recent studies have shown that infants with G6PD deficiency have a conjugation problem. This is now a worldwide problem. If you are suspicious, testing should be performed. Breastfeeding jaundice and breast milk jaundice are topics that deserve their own mention later on this talk. Premature infants have exaggerated problems with respect to all of the aforementioned physiologic challenges of term infants. Next slide, please. Here is an autopsy case of a preterm infant with the typical pronounced yellow staining of the basal ganglia. Extremely low birth weight infants less than 1,000 grams at birth are at very high risk of bilirubin toxicity, as they also may have comorbid conditions such as lower serum albumin and acidosis. Both of these promote increased free fraction of bilirubin for entrance into the brain. What is interesting to me as a neonatologist is that we constantly have infants in the first 1 to 2 weeks of age who have excessive twitching or startling or extrapyramidal-like movements that we attribute to immaturity. At least this is what we believe and tell the parents. Many of these infants are under phototherapy prophylactically during this time and face difficulties with persistent acidosis with pH of 7.14, 7.17 that we try to fix. I wonder if these abnormal movements could possibly be some form of bilirubin toxicity. You know that the acidosis promotes release of free bilirubin from albumin, and it also increases cerebral blood flow, making the brain even more accessible to free bilirubin. Just food for thought for the neonatologists. Next slide, please. The AAP subcommittee has advocated that everyone involved in neonatal care must work together in order to achieve our goal of preventing severe hyperbilirubinemia and bilirubin encephalopathy. These three elements are key: universal systematic assessment, close follow-up, and prompt intervention. Next slide, please. Since most of the babies that slip through the cracks were breastfeeding, we must promote successful breastfeeding. Now our babies stay in the hospital longer, and we have built-in lactation specialists that teach new mothers and keep themselves available by telephone for questions. Most pediatricians are also seeing their newborns earlier, many within 2 to 3 days of discharge, so that they can troubleshoot early feeding difficulties or jaundice. Data from a number of studies indicate that unsupplemented breastfed infants experience their maximal weight loss by day 3. And 5 to 10% of such infants lose 10% or more of their birth weight by day 3. This should be a red flag, and these infants should be monitored carefully for adequacy of intake and need for help with breastfeeding. Nurses are now able to order a serum bilirubin test if they feel the baby needs it. In the morning, when the pediatrician sees the baby, he or she may be mildly yellow, but late in the day, the jaundice may be more intense. Thus far, at JFK, we are only using serum bilirubin levels. Though most hospitals are now using transcutaneous devices as they have become more reliable as screening tools, we may eventually use such non-invasive devices at JFK that in the long run are designed to limit costs, limit painful pricking of the baby's heels, and decrease parental anxiety. Next slide, please. Tsb measurement is the traditional and most widely used method for screening and diagnosing neonatal hyperbilirubinemia. But the blood draw is invasive and carries a risk, albeit low, of infection and anemia. Transcutaneous bilirubin assessment is a non-invasive alternative that generally correlates well with Tsb values up to 15, even in Hispanic, African, and multi-ethnic populations. But these should not replace Tsb measurement. Diagnosis of hyperbilirubinemia is made with Tsb or TCB measured at greater than 95th percentile for age in hours. When the TCB levels are measured at greater than 15, it should be confirmed with a Tsb measurement. Next slide, please. We all know that visual assessment can lead to errors. When in doubt, order a serum bili especially in infants with darkly colored skin. These body zones were taught to us as residents, but how many times were we fooled by jaundice? If the icterus is just in the sclera, the estimate is 3 mg/cent. From neck, for zone 1, from neck up, 8 mg/cent. Zone 2, neck down to the umbilicus, 5 to 12 mg/dL. From umbilicus to knees, zone 3, 8 to 16. Zone 4, from knees down to the ankles, 11 to 18. From ankles down, extreme, 35 mg/dL. But again, visual assessment can lead to errors, so you have to use TSB or TCB measurements. Next slide, please. Butani and colleagues developed the R-specific nomogram. Never think of bilirubin levels in terms of days, especially in the first 72 hours. Next slide, please. This nomogram was designed by obtaining the serum bili level of almost 3,000 term and near-term infants just before discharge. The zone in which the bilirubin level fell predicted the likelihood of the baby going on to have subsequent bili level exceeding the 95th percentile or high-risk zone. High-risk zone, 95th percentile, high intermediate risk zone, 75th percentile, low intermediate risk zone, 40th percentile, and below that is the low risk zone. Next slide, please. In some nurseries, we have a more comprehensive sheet that helps our nurses keep track of the biliary levels by hour of age. However, the nomogram is not designed to describe the natural history of neonatal hyperbili. Rather, it is only to be used as a predictor of risk. They also have a checklist of important risk factors that help determine whether the baby is more prone to rise into the high zone. And both the admitting and discharge RNs must sign the sheet and therefore have analyzed everything involved before the baby goes home. Pediatricians and residents also refer to this sheet in their decision-making processes. It helps determine who may need photo, who may need a bili check one day after discharge, or who they should see in the office the next day. With this system, no babies should be missed. Next slide, please. This just gives the breakdown of the actual number of infants involved who subsequently went on to develop TSB greater than the 95th percentile. So as you can see, 172 newborns were in the high-risk zone, greater than 95th percentile, and of these, 68, nearly 40%, went on to develop severe hyperbili. Approximately 13% in the high intermediate risk zone, 2.26% in the low intermediate risk zone, and none in the low risk zone. Next slide, please. The incidence of kernicterus is not known, but the estimated risk for kernicterus for screening total serum bili levels using population-based data from developed countries indicate that the risk of kernicterus is rare for total serum bili greater than 20 to 25, and almost all infants will have signs of kernicterus when the total serum bili is greater than or equal to 35 mg/cent. Next slide, please. The AAP phototherapy curve is commonly used to determine phototherapy thresholds for infants with hyperbilirubinemia. The nomogram applies the total serum bili level and age in hours to a low, medium, or high risk curve that is determined by gestational age and the presence of neurotoxicity risk factors such as Isoinbian hemolytic disease, G6PD deficiency, asphyxia, sepsis, acidosis, albumin less than 3 grams per deciliter. Next slide, please. Infants on the medium and high risk curves, the middle and the solid line, have lower thresholds for initiation of phototherapy. The majority of infants born at gestational age greater than or equal to 38 weeks being cared for in the newborn nursery will be assigned to a low risk curve, the topmost curve. On the AAP phototherapy nomogram, as many of the neurotoxicity risk factors that elevate risk would also be reasons for infants to be in an intensive care unit. Next slide, please. Online calculators and apps based on the AAP phototherapy nomogram, such as the BiliTool, bilitool.org, offer recommendations for phototherapy thresholds and may suggest a time interval at which to repeat bili testing if phototherapy is not indicated. Again, these are the guidelines for phototherapy. The committee admits that these are based on limited evidence and are only approximations, but they are still helpful in determining who should get started on phototherapy. Next slide, please. This just shows again the botanic curve or the R-specific nomogram as a predictor of risk, with the concurrent recommendations when to repeat bili testing until bili levels are in the low risk zone. Next slide, please. This table shows the assessment, intervention, and follow-up strategy based on universal bili screening in newborn. For instance, total TSB in the high-risk zone, in the presence of hemolysis, intensive phototherapy should be started for TSB rate of rise of greater than 0.2 milligram% per hour and promote breast milk intake. For low-risk TSB levels under 40th percentile without clinical risk factors, we just do routine newborn care and promotion of enteral feeds or breastfeeds, then routine newborn follow-up at age 3 to 5. Next slide, please. We also have guidelines for exchange transfusion. Again, these are based on limited evidence and mainly a consensus from the experts on the committee. Of course, in-hospital infants would receive intensive phototherapy first, and similarly for readmitted infants, if TSB is above the exchange level, start with intensive photo first, repeat bili every 2 to 3 hours while waiting for the blood that you prepared, do the exchange if the level remains above the indicated line for 6 hours. Next slide, please. Now, in order to identify those babies who are at risk for Isoinbian hemolytic anemia, all pregnant women should be tested for ABO, RH, and any unusual Isoinbian antibodies for which she may be sensitized. Occasionally, we identify mothers who have anti-Cal, anti-small c, or anti-big E antibodies that can be just as clinically significant as RH antibodies. Next slide, please. All of our babies at JFK receive cord blood typing and CUMS testing regardless of maternal blood type. This may not be the most cost-effective method, as only those infants of mothers who are O positive or Rh negative are required by the guidelines to be tested. Next slide, please. I always like to review this because we often forget the difference between the direct and indirect Coombs test. Baby's blood is drawn and sent down to the lab already coated with antibody. We don't know that, however, until we add anti-IgG antibody so that we see the precipitate in the test tube making the test positive, DAT test positive. Next slide, please. The indirect Coombs test is performed every day in the hospital, as it is really the maternal antibody screen. In the lab, they have a large supply of stock red cells, each with a specific antigen. Mother's blood is drawn and her serum is added to these stock red cells. This mother's serum has an antibody, you add the anti-IgG antibody, and you get precipitation, resulting in a positive maternal antibody screen. However, the vast majority of the moms have a negative antibody screen and show no precipitation when anti-human antibody is added. So this test will pick up, for instance, the rare anti-small c antibody or other minor blood groups. Then the obstetrician knows that the mom has a clinically significant antibody. Next slide, please. What puts newborns at risk? Those that carry the highest risk include gestational age under 38 weeks, having a sibling who required phototherapy. Next slide, please. Visible jaundice by the time of discharge, and exclusive breastfeeding, among others. So these are the major risk factors. Next slide. The minor risk factors include pre-discharge TSB in the high intermediate risk zone, gestational age 37 to 38 weeks, jaundice observed before discharge, among others. The more risk factors present, the higher the risk. Next slide. Infants who are formula fed and post-term greater than or equal to 41 weeks or have no major or minor risk factors have a very low likelihood of developing severe hyperbilirubinemia. Next slide, please. This is a useful mnemonic. Jaundice, J, jaundice visible on the first day of life. A, sibling with neonatal jaundice or anemia. U, unrecognized hemolysis, whether ABO or RH. UGT deficiency, Crigler-Najjar, and non-optimal breastfeeding or breastfeeding jaundice. D, deficiency of G6PD. I, infection, infant of diabetic mother, macrosomic immaturity. C, as in cephalhematoma or polycythemia, central crit greater than 65%, and the East Asian race. Next slide, please. Since most of the infants that fell through the cracks were breastfeeding, I think this topic deserves special mention. Next slide, please. Breastfeeding jaundice, they have decreased milk production, decreased milk letdown, decreased caloric intake or starvation, decreased fluid intake, delayed passage of meconium. So all of these lead to an infant at higher risk for hyperbilirubinemia. Dehydration and lack of calories promote jaundice because of the many reasons previously discussed. These babies have a hyped up enterohepatic circulation. Their bowel motility is down, their enterohepatic circulation is extremely active, few stools are passed, bilirubin is therefore retained. Correcting dehydration in these babies is not enough. Supplementing with sugar water will only make matters worse. The baby needs calories to get the gut moving. So the recommendations are for close lactation follow-up and promoting 8 to 12 feedings per day to get the cycle going, and this will also increase mother's milk production. The AAP advocates supplementation with formula, especially for the 35 to 37-week infant who is experiencing weight loss and increasing jaundice. Next slide, please. This just compares the jaundice etiologies. Breastfeeding jaundice may lead right into breast milk jaundice, or breast milk jaundice will creep up on its own in the relatively healthy term and near-term infant. You can see in physiologic jaundice, the onset is after 36 hours, whereas breastfeeding jaundice 2 to 4 days, breast milk jaundice 4 to 7 days, and the peak TSB occurs on day 3 to 4 for physiologic, day 3 to 6 for breastfeeding jaundice, and 5 to 15 days for breast milk jaundice. And 56% of infants have physiologic jaundice, and about 12 to 13% breastfeeding jaundice, 2 to 4% breast milk jaundice. Next slide, please. This is the recent data from the American Academy of Breastfeeding. Like typical time frame for suboptimal intake jaundice or breastfeeding jaundice is 2 to 5 days and usually resolved by 2 weeks. And they have ongoing weight loss and few stools and urine output. Commonly under 38 weeks, and rarely greater than 40 weeks may be fussy and difficult to settle between feedings, or sleepy and difficult to wake for feeding. Whereas breast milk jaundice, the onset is 2 to 5 days and may last up to 3 months. They are thriving with good weight gain and good stooling and voiding. Next slide, please. Next slide. Breastfeeding is related to the lower half of this slide, as breastfeeding does not promote increased bilirubin production. Rather, breastfed babies have decreased bilirubin excretion. Factors in breast milk have been accused of interfering with bilirubin conjugation or disrupting bilirubin glucuronidase, such as pregnenolone, fatty acids, and lipase. However, no study has firmly resolved this issue. Beta-Glucoronidase, besides being abundant in the newborn infant's gut, believe it or not, it is also present in breast milk. So they get an extra load of this enzyme. And remember, this enzyme is very adept of breaking down bilirubin glucuronidase to unconjugated bilirubin. So these babies have enhanced or hyped up enterohepatic circulation, getting the bilirubin back into the circulation. Next slide, please. This slide just shows the transcutaneous jaundice index in newborns fed human milk. As you can see, it's high. It's highest in infants who are fed human milk and lowest in infants born fed with elemental formulas such as Nutramigen. Next slide, please. Now we go to treatment of hyperbilirubinemia, which include promotion of enteral feeds, phototherapy, and exchange transfusion. What is the biochemical basis of phototherapy? Well, phototherapy detoxifies bilirubin and does not rely on conjugation in the liver. Next slide, please. And there are 3 photochemical reactions: photooxidation, which plays a minor role, which involves disruption of the bilirubin molecule to form colorless polar fragments that are easily excreted in the urine. This is the reason why we shouldn't expose the serum samples to direct light. 2, configurational isomerization, which plays an intermediate role, and structural isomerization, which plays the major role. The formation of the structural isomer bilirubin, which is irreversible. Next slide, please. Light directed at the skin converts bilirubin to lumirubin, a compound that, unlike bilirubin, does not require conjugation in the liver and can be directly excreted in the urine or bile. Next slide, please. Infants with bilirubin levels greater than 25, those who are not responding to intensive photo, and those with evidence of ABE should be treated with exchange transfusion with initiation based on an infant's age in hours and neurotoxicity risk factors. And approximately 12% of infants have a complication from exchange transfusion, including infection, electrolyte imbalances, thrombosis, thrombocytopenia, and necrotizing enterocolitis. Next slide, please. Other management strategy includes IVIG, which has been very helpful for infants with hemolytic disease. With intensive phototherapy and IVIG, we have averted the use of exchange transfusion. The other studies are still, useful in lowering the bilirubin levels, but we don't know the safety and long-term outcomes. Next slide, please. What are the insufficiencies and controversies? The exhaustive meta-analysis undertaken by the AAP subcommittee on hyperbilirubinemia was based on very limited information. A lot of times it seemed that they were comparing apples to oranges and had to make sense of a vast number of small, non-randomized studies. We will never be able to understand how well the new guidelines are working and how many babies we are helping to avoid kernicterus if we don't know the actual number of cases that are still occurring each year. The kernicterus pilot registry is only a voluntary registry. I believe the CDC would be instrumental in making this a reportable disease. Should there be a national campaign to measure the unbound fraction? Free bilirubin has been researched and proclaimed to be a better marker of true bilirubin toxicity than Tsb. Since the unbound bilirubin can cross the blood-brain barrier, increased bilirubin albumin ratio could theoretically be a predictor for bilirubin encephalopathy, but Iskander and colleagues found that it was not superior to Tsb levels in predicting neurotoxicity. Untitled CO2 monitoring may help identify children with ongoing hemolysis. The argument comes from the wide range of biliary levels that have been associated with kernicterus. Some feel that the Tsb is adequate as long as the guidelines are followed. Others feel the free bilirubin will limit excess cost and treatment and would be helpful for the preterm infant with many comorbid conditions. Next slide, please. There is a lack of consensus among professional societies on appropriate screening for neonatal hyperbilirubinemia, likely due to limited available data, necessitating expert-driven recommendations. The AAP and the Canadian Pediatric Society recommends universal screening, but the US Preventative Services Task Force and UK do not support universal screening. Next slide, please. Recent papers show that the cost estimates based on the kernicterus pilot registry show a heavy financial burden compared to number of infants spared. Most would argue that the money should not be the object in trying to prevent this disease. As Jeff Meisel stated in a 2004 letter in Pediatrics, quote, "As with many conditions in pediatrics, It is necessary to evaluate and treat many infants to spare a few from irreparable harm, unquote. Next slide. What is the take-home message? Well, kernicterus is still happening. It happens in healthy newborns that are discharged from the hospital, particularly breastfed babies. So prevention is key. And with the heightened vigilance, neonatal hyperbilirubinemia has become the most common hospital readmissions in newborns and represent a significant healthcare cost. So as I said, prevention is key. So we have to work together. We have to provide education of parents from the get-go, promotion of enteral feeds, and successful breastfeeding in collaboration with parents. So as soon as we see them, we enlist the father even, that golden hour is key. If you start breastfeeding early and frequently, every 2 to 3 hours, promoting 8 to 12 feedings a day, the cycle gets going and milk will come sooner, and you promote successful breastfeeding. And this will facilitate timely discharge and avoid hospital readmission for significant jaundice and weight loss. As mentioned, 3 elements are key: systematic assessment to identify infants at increased risk for severe jaundice, close follow-up, and prompt intervention. TSB is the traditional method for screening and diagnosing neonatal hyperbilirubinemia, but there is a role for TCB screening, a good, reliable, non-invasive alternative, but not a substitute. It is reliable up to 15 when the TCB level is greater than 15. It requires TSB confirmation, or when there's a need for initiation of phototherapy, or it's 2 to 3 mg% for close to phototherapy, then you have to confirm with a TSB level. Thank you so much for coming, and thank you for listening.
Thank you so much, Dr. Tumbaga. We are just at time, but I would like to squeeze a couple questions in that we did get. One question is, during COVID, many newborns have been discharged earlier. Has that led to a higher rates of hyperbilirubinemia?
Well, it depends on the practice. In the short time that I've been at JFK, with the heightened vigilance, as I mentioned, there has been, a lot of readmissions. But what I've noticed, if you involve the parents from the get-go, like especially after the baby is born, you are present, you enlist the father, while the baby's just born, and you can distract the mother from the pain while they're finishing up. You discuss about early breastfeeding, that golden hour, and the promotion of 8 to 12 feedings a day. I feel that even with the COVID, I don't believe that there has been an increase. The one that's increased are those with significant risk factors that oftentimes, like some nurses are saying, the parents were not really listening, so because the baby goes home with good intake, good voiding, and then comes back with significant weight loss and not enough intake, then the bili is high. So it's hard to say. It depends on where you are and how the clinical practice has been. It's a very good question, though.
Yeah, and it sounds like having that teamwork, as you mentioned, makes a big difference. And one last question, if I can just squeeze it in. When it comes to breastfeeding and bottle feeding, if a baby is exclusive bottle feeding but is receiving breast milk in it, is the risk still elevated?
It's not as much, because the key, like I said, is promotion of successful breastfeeding. So with cow's formula, there is decreased reabsorption of bilirubin. That's why there's less risk. So the key is good intake, good voiding and stooling. And that's why I've seen, like, I get phone calls from pediatrician. You know how the babies pick Billy happens when they're home, and they also have, like, for breastfed babies, they experience maximal weight loss on day 3. I get a phone call from a pediatrician. It's already 10%, but the milk is in. The Billy is in the high risk zone, but it's 40 weeks gestation. So what I've done, and I've been following the trend, is they do the Billy check in the morning, they check it in the afternoon, and then it goes down to the low, from the high risk zone to either high intermediate or low intermediate. So if that happens, I tell them close follow-up the next day, monitor adequacy of intake, supplement as needed. And sometimes I don't even supplement for those term babies, not late preterm. The late preterm babies, the lower gestational age, and the exclusive breastfeedings are the ones at highest risk for jaundice. These are the ones that you carefully follow. So to answer your question, mixed breast and bottle shouldn't make a difference. What will make a difference if there's inadequate intake?
Okay. Great. Well, thank you so much, Dr. Tumbaga. We really appreciate you having with us today. So we also want to give thanks to Kara Mamadeo, who's handling the technical back end of the program, and everyone here who has joined us today. As a reminder, you will receive a link to post-program evaluation. Your feedback is important, so please take the time to complete. Certificates of completion will be sent